Let us proceed to the second session on the topic Clinico-Pathologic Correlation in Oral Pathology case discussion by Dr. Ragesh S., Dr. Mahija Janardhanan, and Dr. Vindhya Savitri. Dr. Ragesh S. has completed his BDS from Annamalai University, Tamil Nadu in 1997 and MDS in Oral Pathology and Microbiology from Rajiv Gandhi University of Health Sciences in 2002. Sir is a professor and head of the Department of Oral and Maxillofacial Pathology and the Vice Principal, Amrita School of Dentistry. Sir is also the Assistant Controller of Examination, AIMS Health Sciences Campus, and the member of Board of Studies, Amrita Vishwa Vidyapeetham. We welcome you, sir.
Thank you, Dr. Charlene, for those words of introduction. I hope I am audible.
Yes, sir, you are audible.
Just
Dr.
give me a moment. Okay. Please tell me when I should share the screen.
Sure, sir. Dr. Mahija Janardhanan completed her BDS degree in 1997 and MDS in Oral Pathology and Microbiology in 2003 from the Mahatma Gandhi Postgraduate Institute of Dental Sciences and Research Center, Uchedi. Ma'am is pursuing PhD in the field of oral cancer immunology at Amrita Vishwa Vidyapeetham. Ma'am is also the faculty in charge of gender sensitization and empowerment cell of the Amrita Health Science Center. At present, ma'am is working as a professor, Department of Oral and Maxillofacial Pathology, Amrita Vishwa Vidyapeetham. We welcome you, ma'am.
Thank you so much.
Dr. Vindhya Savitri has completed her BDS in 1999 and MDS in Oral and Maxillofacial Pathology in 2005 from Government Dental College, Kozhikode. Ma'am is an additional professor in the Department of Oral and Maxillofacial Pathology, Amrita School of Dentistry. We welcome you, ma'am.
Thank you.
I also invite the chairpersons for the session, Dr. R. Reddy, ma'am, and Dr. Shamina PM, ma'am. Dr. R. Reddy, the professor and the head, Department of Oral and Maxillofacial Pathology, and Vice Principal, Assisia College of Dental Sciences and Research Center. We welcome you, ma'am.
Thank you so much.
Dr. Shamina PM is a professor and head, Department of Oral and Maxillofacial Pathology, Government Dental College, Kozhikode. We welcome you, ma'am.
Thank you.
It's over to you, Dr. Ragesh Suresh, sir, for case discussion.
Thank you, Dr. Charlene.
Welcome, sir. Please share.
I'll just share my screen. I hope the screen is visible.
Is it visible?
So a very good morning to all the delegates and the respected chairpersons, Radhi ma'am and Shamina ma'am. It really fills us with confidence and support to have you as the chairpersons for this session. So thank you very much, Radhi ma'am and Shamina ma'am, for your esteemed presence. So we bring you greetings from Team Amrita Oral Pathology to this session on case discussions. Now, before we formally begin, we would like to extend our humble salutations to the senior teachers who have held our hands and who are still there to guide us at every step. We are indeed blessed to have them. And also to Team Pushpagiri, Dr. Sunil, Dr. Charlene, Dr. Arjun, and Dr. Tibia, and the entire team of Pragya for having had the confidence in us and given us this opportunity to share, especially for the benefit of the PG students. And also to the KSOMP, Dr. Nivedita, Dr. Anila, and all the office bearers for having given us this opportunity. So the aim of our presentation, if I tell you, taking you back to the pre-COVID times when we used to have physical conferences, it used to be like we project a slide and then we give a minute to the PG students to look at the slide, think over, and then give us their interpretation. And then we used to go ahead. That is what we were blessed to have, that sort of a slide discussion for all our conferences from our senior teachers, and that has helped us a lot. Unfortunately, with the advent of COVID, when all these conferences became virtual, I think the physical distance and the time constraint does not allow us to have this luxury. So what we intend to do in this, in the next 1.5 hours, especially for the benefit of our postgraduate students, we will be sharing all our slides, cases, and views. Please try to understand them within the time limit which is allotted to us. And whatever doubts you may have, our numbers, contacts are very much there in the KSOMP group and with the organizers. You can message us in person. We will always be there to reply to you, to your doubts. So with this, one more thing, which I want to remind the PG students. See, once you start your pathology reporting, don't always expect that you will be coming across complex or very complicated lesions. 90% of the times, the slides which will be coming to us will be simple, common day lesions. So our primary aim should be, we should be in a position to identify those simple lesions. Yes, once in a while, we may get complex pathologies. So that is why we are updating you with how to diagnose the complex pathologies too. Not because you will see them every time, but when it comes to you, you should be in a position to diagnose them. So with this background, let me begin Team Amrita's presentation, going on to our first case. So you can see a clinical picture here, which shows a slow-growing nodular lesion on the palate in a 40-year-old female patient. So these are the clinical details which are given to you. And the radiographic findings were not significant. So the bone was not involved. So that tells us that this was a soft tissue lesion. A lesion nodule on the palate. It's a little bit diffuse, you can see that. Now, the next thing, when you should have all the clinical and radiographic details with you, don't jump into the slide. The next thing what you should formulate is a clinical differential diagnosis. Why is this important? Because that will help you to approach the slide. So when you have a nodular lesion on the palate, which is slow growing, you will have an idea about the lesions which can commonly occur on the palate. So we should narrow down our diagnosis to this spectrum. So that is very, very important before you start scanning the slides. So for every case you see, every slide you see, once you get the clinical details, you go into a clinical differential diagnosis, you frame it in your mind. So now if you ask me, what are these lesions which commonly occur on the palate? You can have benign salivary gland neoplasms, which occur. Palate is one of the most common site for the minor salivary glands. Odontogenic, any tooth-related lesion can manifest on the palate, especially from the maxillary dentures. Infections, yes, commonly they can occur on the palate. And of course, you should also consider benign connective tissue neoplasms. So this exercise will hardly take around 1 or 2 minutes for you to frame the lesions which commonly occur at the site given according to the clinical and radiographic findings. So once we have this set of clinical differentials, we go on to the pathology. Now you have a beautiful photomicrograph here, which shows you a low power view. So you have a ribbon-like band of epithelium, superficial epithelium, a sort of fibrous tissue, which is separating the epithelium from the lesional tissue here. So from the look of it, it looks well circumscribed. It's a nodular lesion. So you can see the reflection of that in the histopathology. So what do you infer from this? It is cellular. You can see that the lesion is quite cellular. Looking at certain areas, you are able to see some eosinophilic areas in between, but not many. It is predominantly cellular. And deep down, you can see some peculiar arrangement of the collagen fibers. You can see some blood vessels here. So these are all the features what you can make out in the low power. So with this, let us go to a higher power. focusing on the cellular area, you are seeing fascicles. So whenever you see spindle-shaped cells which are proliferating in a particular elongated fashion, you call them as fascicles. Remember, fascicles are usually the property of proliferation of connective tissue cells. Epithelial cells usually, they do not proliferate in fascicles. They proliferate in islands, nests, or sheets, and they have a distinct round to polyhedral appearance if they are well differentiated. So here, they are predominantly spindle-shaped. You can see them. They are proliferating in fascicles. In certain areas, you can see hypocellularity. So areas which are hypercellular, areas which are hypocellular. So other than that, you are not getting more details here. So let us have a close-up view of these cells. Now it is a little more clear. You can see the hypercellular areas as well as the hypocellular areas. The hypocellular areas appear more myxoid with only some sprinkling of cells which appear more rounded. In the hypercellular areas, you can see the fascicles, and in many areas, you can see a sort of a palisaded arrangement, but nothing more than that. There was one focal area which showed this particular arrangement. So here I would like to emphasize the importance of scanning the entire slide which is given to you, or all the sections which are given to you before you report the slide, because you may miss out some important areas which will give you a clue to diagnosis. So in this particular slide, majority of the areas showed this picture, but only in one focal area we could find this particular picture. And this picture holds the key to your diagnosis, easy diagnosis, I mean. So you have the typical palisaded arrangement of the spindle cells around eosinophilic masses. So now I think it is clear to you. It looks as if they are Antony A type of tissue and the Verroque, which are arranged around the Verroque bodies. These are the more organized type of tissue which you see in schwannomas. It appears like that. So what is your diagnosis? Now, before you go into your diagnosis, always take a minute and recall the positive features which you saw in your histopathology slide, because that will help you to come to a conclusive diagnosis, at least a differential diagnosis. So if you look at the positive histopathologic features in this slide, what were they? You had a well circumscribed tumor mass with hypercellular and hypocellular areas. The hypercellular areas were spindle cells, which in one focal area, majority of the areas, they were fascicular. In one focal area, you saw a palisaded arrangement around eosinophilic masses. Probably they are Verroque bodies. And the hypocellular areas are less organized. They have a myxoid appearance. So this goes well into the features of the Antony A, Antony B type of tissue, the Verroque bodies, all representing schwannoma. So had you missed this particular focal area where you saw that Antony A type of tissue and the Verroque body, things would have been a little difficult for you, because without proper Antony A and Antony B type of tissue, you cannot give a straightforward diagnosis of neurilemoma. So that is the importance of scanning all bits of tissue which are there on the slide and all the sections which come to you. Closely related tumor, which has to be distinguished many times when you don't have Antony A and Antony B type of distinction. Another tumor which you need to closely differentiate is the other neural tumor, neurofibroma. So neurofibroma is a little different. If the features usually which are representative of neurofibroma are there in your slide, you get a more collagenous matrix in neurofibroma with two type of cell populations. One is the very spindly type of cells with the wavy nuclear outline, which are the Schwann cells. The ends will be pointed. They will not be blunt like the fibroblasts. They are pointed. So they'll have a wavy outline, and they are the Schwann cells. The other cells are the perineural fibroblasts, which are more stellate or angular. So you can see both the cell populations here. Unlike in neurilemoma, where spindle cells predominate and they are arranged in a palisaded fashion. Apart from that, the collagen many times when you see in neurofibroma will appear like shredded carrots, a little different from what you find in neurilemoma, with lot of blood vessels in the background and a sprinkling of mast cells. So when you find that the features of neurofibroma are quite indistinguishable from neurilemoma, this is one feature which you can look out for. In the background, if you look carefully and if you are able to see a few mast cells, that goes more in favor of neurofibroma when you have a dilemma between the two lesions. So another entity which we are likely to come across is the plexiform type of neurofibroma, which is usually seen in neurofibromatosis, associated with neurofibromatosis cases. So when you have neurofibromas biopsied from neurofibromatosis cases, they are more likely to be plexiform with bag-like arrangement, which are just like, they are follicular, arranged in follicles. Moving on to the next case, case number 2. You can see a radiolucent lesion in the right posterior mandible in a 37-year-old male patient. So definitely it is an intrabony lesion affecting the posterior part of the right side of the mandible in a 37-year-old patient. So as going by what I said, what should you do next? Go into the clinic, get clinical differential diagnosis based on what you have, the features, clinical and radiographic. So these will be my clinical differentials. All said and done, it is a mandible. So whether if the lesions occur in the mandible or the maxilla, you will always have to give the benefit of the doubt to odontogenic lesions. We don't know whether they will ultimately turn out to be odontogenic, but we should always consider odontogenic lesions as one of the clinical differentials when you see lesions in the maxilla or mandible. Connective tissue pathology, fibro-osseous lesions. You can also think very remotely of intra-bony salivary gland pathology. So with these clinical differentials, we approach the slide. So what do you see here in low power? You're seeing a cellular mass. This picture doesn't show you any superficial epithelium clearly because it is an intra-bony mass. It is a central lesion. So you have the lesion proper probably here showing you a cellular lesion. You are not able to make out clearly the morphology of the cells, but they look like spindle cells here. Some eosinophilic areas are seen here. You can also see increased amount of hypocellular areas in between, which appear eosinophilic, where there are no cells. So these are all the areas which you can see, and something looking like empty spaces probably could be blood vessels. We don't know in this magnification. Let us go on to the next magnification. You have a important feature here. It is capsulated. You can see a fibrous capsule. And since I'm not able to show you the entire field, let me tell you, the entire lesion was capsulated. Means in many areas, it had an intact capsule. And you can see some hypocellular areas here immediately below the capsule. But this particular area appears hypercellular, and you can make out what looks like streaming fascicles. When the fascicles are parallel to one another, like a stream, flowing stream, you call them streaming fascicles. So the moment you say fascicles, what will be the morphology of the lesion cells? It will be spindle cells. So you can see spindle cells, which are in fascicular pattern, more areas which are cellular, and hypocellular areas, myxoid areas. But what predominates here is a huge blood vessel with hemorrhage inside. You can see the blood as well as the fibrosed wall. The vessel appears to be fibrosed. So another area, high power view of the cellular area, the fascicles. Now take a look at the morphology of these spindle cells. They are not the wavy spindle-shaped cells which usually you tend to see in neural tumors. They are more plump, they have a vesicular nuclei, open-faced nuclei, so they are actively proliferating. But they appear isomorphic. They are not pleomorphic. You cannot appreciate any obvious mitotic figures. In between, you can see some round cells. Probably they are inflammatory cells. At this magnification, we are not able to make out. You can also see some blood vessels in between. In focal areas, we saw tissues which gave us a clue. These were the cells which we saw in the earlier slide. Some slender, parallelly arranged. It looks like nerve tissue. So areas resembling nerve tissue were there in one or two corners of the sections what we got. And the wavy nuclear outlines, they look like, this is what looks like a nerve tissue. Only in these focal areas. And one more area where you had hypocellularity with lot of hemorrhage, vascularity and hemorrhage. So this is all what we saw. Now what do we do before going on to the diagnosis? We sum up the positive histopathologic features, what we saw. You can see an encapsulated tumor tissue composed of proliferating spindle cells. Those were the predominant cells. The spindle cells focally in one area gave a palisaded appearance. They appeared streaming fascicles in most of the areas, plump and stellate shaped. In majority of the areas, they had a hyperchromatic nuclei. Most of them were open-faced also. Blood vessels, positive areas of hemorrhage, no features of cellular atypia and necrosis. Now, since you are not able to get spindly cells with the nerve tissue outline, you cannot focus on or arrive at a diagnosis of a nerve tissue tumor here or a nerve tissue lesion. So all what you can do is think of lesions which will give you such spindle-shaped appearance. So you can give it as a benign spindle cell lesion at this stage, nothing more than that, because you don't know what is the origin of the spindle cells. You are at a dilemma. You have to ascertain the origin. So now what do? Think of the differentials of these benign spindle cell lesions. So the benign connective tissue lesions which show a spindle cell pattern, you have nerve tissue, neurolemoma and schwannoma, neurofibroma, muscle. Since we more or less know that it is benign, we don't have to look into malignant right now. Leiomyoma, smooth muscles are benign, whereas rhabdomyoma, they are mostly round. The spindle cell is very rare. It's only one of the variants. So leiomyoma is smooth cell lesion, spindle cell lesion. Fibroblasts, fibromatosis, yes. Inflammatory myofibroblastic tumor and myofibroma, they are thought to be myofibroblastic in origin. I will come to that a little later. Solitary fibrous tumor, earlier what was named as hemangiopericytoma, has now come into fibroblastic origin. Solitary fibrous tumor, according to the 2013 WHO classification. So now the hemangiopericytoma word is not used, though we tend to use it in day-to-day pathology. The word is no more there according to WHO. It is solitary fibrous tumor and a fibroblastic tumor. It has three spectrums. It can be completely spindle celled. It can be a mixture of spindle cells and vasculature like staghorn. It can be predominantly vasculature. So these are the three spectrum of solitary fibrous tumor. In vascular tumors, spindle cell hemangioma. So you have to think of all these. What is the need for you to think of or arrive at a differential of these spindle cell lesions? Why can't you straight away go into immunohistochemistry? Because you have to decide on a panel. See, you are going to burden the patient further by ordering a panel of IHC markers. So you have to think from the patient's point of view. You just cannot give straight away, start from cytokeratin, all possible markers. No. See here, this is an intrabony lesion, a spindle-shaped lesion. There is no rationale in advising a cytokeratin marker in the beginning here. Once you give all the possible probable markers, they are all negative. As a last resort, you can go for the least possible markers if you don't get anything positive. So that is the importance of coming at arriving at a histopathologic diagnosis here before going on to the panel. So with this histopath differentials of spindle cell lesions, we did an S100 first. Obviously, we wanted to rule out nerve tissue. That turned out to be diffusely positive. So what does it represent? It represents nerve tissue. Smooth muscle actin was negative. So that rules out lesions from smooth muscles and myofibroblasts, leiomyoma, myofibroma, IMT. Further, we wanted to rule out smooth muscles again. Desmin, smooth muscles, leiomyoma was ruled out. CD34, since we saw blood vessels, we wanted to rule out a vascular origin, spindle cell hemangioma. So SFT also, the solitary fibrous tumor, because there are a lot of hemangiopericitomatous patterns which are there. It is positive for vascular markers. So SFT was ruled out. Ki67 gave up 3 to 4%, the proliferation marker. So that gave us an idea that it was completely benign. So with this, the first panel of markers, we were able to get a diffuse positivity with S100. So what does it tell you? It was an intrabony benign spindle cell neoplasm of nerve tissue origin. We gave it as an ancient schwannoma. Why did we consider that? Now, ancient schwannomas are schwannomas of longer duration with any one or more of the following criteria which are seen in the histopathology. Unlike the conventional schwannomas, which we saw initially, the typical Antony A, Antony B areas, there will be more hypocellular areas. Hypercellularity will reduce and there will be more of hypocellular areas. The features marked in green are the ones which we saw in our case. Relative loss of typical Antony A tissue. We didn't see much of that. More of vascularity and hemorrhage. We saw that. Fibrosis of the vessel walls. We saw one vessel which was, typically fibrosed. Other features which you can encounter in ancient schwannomas are extensive cystic degeneration, nuclear atypia and pleomorphism. Here you have to be careful because that will give you an erroneous diagnosis of a malignant tumor. Fortunately, we did not find such areas here. So we could totally rule out malignant tumors in the H&D sections itself. Otherwise, you will have a dilemma there. You will think of a malignant neoplasm also in your H&D diagnosis. So that is about ancient schwannoma. I want to give you an update of the 5th edition, that is the 2020 edition of the WHO classification of soft tissue tumors here, especially PG students who are going to appear for their exams. This will be an important information for you. The entity called melanotic schwannoma was there until the 2013 classification. It was considered benign, but showed aggressive behavior. They had still put it under a benign group, but now it has been redesignated as a malignant neoplasm under peripheral nerve sheath tumors, and that is called malignant melanotic nerve sheath tumor. So there are two malignant peripheral nerve sheath neoplasms of the peripheral nerve sheath, which we have to remember now after the latest update. One is malignant peripheral nerve sheath tumor, which we all know, the malignant neoplasm arising from the nerve tissue. There is one more which is added now, malignant melanotic nerve sheath tumor. The melanotic schwannoma has been redesignated. It is MMNST along with MPNST. What is the cell of origin? The precursor cell of Schwann cells and melanocytes. That is why in the histopathology of this tumor, you will have the neoplastic tumor cells resembling both Schwann cells as well as they will produce melanin pigment extensively. They have ability, at least 10 to 20% of them have the ability to undergo local and distant metastasis. That is what prompted WHO to shift it into malignant neoplasms now. Moving on to the third case, a slow growing nodular mass on the dorsum of the tongue. So it is a mass on the tongue, nodule, 32-year-old female patient. I don't have a picture to show you because probably the clinicians also missed clicking the picture, but I think with this much of clinical features, you can think of clinical differentials, lesions which commonly occur on the tongue. That is the clinical differentials which you should think of. Neural lesions, muscular lesions, fibrous tissue lesions, and salivary gland lesions. These are the four major group of nodular lesions which can occur on the substance of the tongue, on the dorsum of the tongue. And you know, I'm not going into the examples for each because that is known to all of you. So with that, we come to the histopathology. Again, sorry for a bad slide here because we could not help it. The sections came out like this, but you are able to appreciate a nodule, a very perfect nodular mass with a strip of epithelium here on the top and what looks like the lesional tissue here. We are not able to make out anything else other than it appears a somewhat round cells which are packed in the connective tissue. Let us go to the higher powers. One feature regarding the epithelium, we scanned all the sections which came to us. In most of the sections, the epithelium was flat without retiridges. But in one corner, we found this. You all know it is a pseudoepitheliomatous hyperplasia of the epithelium. So that we found in one focal area of the on one of the sections. Connective tissue appeared to be densely fibrous, but here it looked as if there are sheets of some round cells with granular cytoplasm. I am 100% sure you all have got the diagnosis by now. But before jumping into the diagnosis, let us take a higher power view of the connective tissue. You have the round to polygonal cells with centrally placed nuclei and a granular cytoplasm. No marks for guessing because now you all have guessed. PG students, you all know what it is. Again, before jumping into the conclusion, take a look at the positive histopathologic features and then go into the final diagnosis. Epithelium, more or less uniformly thick, focal area showing pseudoepitheliomatous hyperplasia, sheets of round to polygonal cells with eosinophilic granular cytoplasm. We found that they are positive with PAS. We did a PAS positivity, we did a PAS stain and found that they were positive with PAS. Vascularity was less. Obviously, there were no blood vessels. So it is a granular cell tumor. Now, when you find granular cells on your slide for reporting or for your examination, always have a ready-made differential diagnosis of lesions which will show you granular cells commonly. You don't have to think of very rare lesions here, but at least which you should commonly know. Granular cell tumor, congenital epulis, granular cell ameloblastoma, oncocytoma, the benign salivary gland tumor, which is also called oxyphilic adenoma, granular cell odontogenic tumor or odontogenic carcinoma, and acinic cell carcinoma. These are all the slides which you are likely to get, in where granular cells are likely to occur. If you find more, you can add to the list. The two which I have highlighted are the most likely which you will have to differentiate. Granular cell tumor and congenital epulis. Granular cell tumor appears later in life in young adults and middle ages. Congenital epulis is present at birth. That is why the term congenital epulis of newborn is found in old textbooks. That is taken off because congenital means present at birth or soon after birth. So it is enough that you name it as congenital epulis. The granular cell tumor is usually seen on the substance of the tongue. Congenital epulis is seen in the anterior maxillary alveolar ridge. Granular cell tumor appears as a diffuse nodule. Congenital epulis is usually a well-defined nodule. Earlier, granular cell tumor was named granular cell myoblastoma because they thought that they are rhabdoid in origin, the round cells which looked like rhabdoid cells. But now, because they are positive for S100, the origin is considered to be neural. They are S100 positive also. Congenital epulis, they are S100 negative, PAS negative. They are now thought to be embryonal hamartomas which arise from the dental tooth germ. So that is the latest hypothesis. Granular cell tumor, you will have a less vascular connective tissue. Congenital epulis, you will have a more vascular connective tissue. These are all minor features. Epithelium, pseudoepitheliomatous hyperplasia is often, not always, but very often encountered in granular cell tumor. If encountered, that is a very typical feature which will help you to identify granular cell tumor from congenital epulis. There, the epithelium will be flat and ribbon-like. So that is again the importance of scanning the entire section and all the slides for the epithelium, whether it is flat everywhere. The granules in granular cell tumor, PAS positive and S100 positive, negative in congenital epulis. Now, in between as a filler, I just want to give you a picture quiz. I won't discuss this case. PG students, you look at the clinical and histopath picture, which I will project for 30 seconds. Form a diagnosis in your mind, keep it. Before I close, after 2 more cases, I will project your answers. Just see whether you have got the right answer. A white patch, a young male patient, a white patch with a granular surface. Very, very, very slow growing. In fact, he didn't even know about it. He came for some other purpose. We actually found it. The clinicians found it and took a biopsy and sent it to us. This is the histopathology. I will be silent. Look at the slide for 30 seconds. Then I will go on to my next case. You can keep the answers with you. I will project the answers at the end of my presentation, so you can just see whether you got it right. I think the diagnosis is very much there. I'm sure most of you would have got the diagnosis also by now. So let me move on to my next case, case number 4. A nodular swelling on the gingiva of a 15-year-old girl, the posterior gingiva, 1 month duration. So you can see the size of the lesion here. Just 1 month duration. Rapid growth, definitely, because it's quite big for 1 month. No bone involvement on radiographs. So what does that tell you? It is a soft tissue lesion. Before jumping into the slide, what should you do? Formulate a clinical differential diagnosis. You have a gingival lesion. It is not a perfect nodule, but a swelling on the gingiva. What are the clinicals which you need to see? Pyogenic granuloma, not a perfect nodule, but still you have to rule out pyogenic granuloma because it is a gingiva. The girl is 15 years. You can have hormonal difference and all that. Other reactive lesions of fibrous origin which can occur on the gingiva. Peripheral giant cell granuloma, peripheral ossifying fibroma, though they are all perfect nodules most of the times, they can be secondarily infected and appear like this. That has to be ruled out. Peripheral odontogenic lesions, they can manifest on the posterior gingiva. So you have to always give the benefit of the doubt, again I would say, to odontogenic tumors or lesions which can manifest peripherally, like peripheral ameloblastoma. Connective tissue neoplasms. So these were the 3 which we considered, giving the thing they were a soft tissue lesion. Now looking at the slide. So looking at this slide, you can see predominantly some hemorrhage. This is a hemorrhagic or vascular area here, which is on the top. Below, you can see 2 zones if you see carefully. In one zone, it is acellular. The cells are less. You can see more of myxomatous type of background. Whereas in the deeper part, you can see a cellular zone. Lot of empty spaces which look like blood vessels. This is what you can make out from the low power. Lot of hemorrhage, lot of cellularity in the deeper part, acellular zone in the superficial area, and lot of blood vessels. Focusing on the cellular area, yes, what we thought were blood vessels are very, very prominent. They are blood vessels indeed. And what is striking with them? Their tortuosity. They are dilated, elongated, tortuous, You cannot see what is a stag horn here, but something which is going into that. They are being compressed by the cell populations which are proliferating around them. So blood vessels are predominating this area. Definitely the cells, some spindle cells are also proliferating around them. Let us take a higher power look at the spindle cells. Yes, they are fascicles. You can see the streaming fascicles here. Probably these are the round cell population, but they may not be exactly round cells. They may be the cut section of the fascicles because they may not be all in the same plane. Here you see the streaming spindle-shaped fascicles. Here it might have been the cross section of those fascicles. So when you see them alternate, you have to always think of cut section of the adjacent fascicles. So such orderly arrangement will not be there in a biphasic population. So that is an important clue to identify biphasic population from fascicular arrangement. Longitudinal section of the fascicles and cross section of the fascicles. A little more clearer picture of the spindle cells. They are spindly, yes, quite plump with hyperchromatic nuclei, but no atypia. They are all monomorphic. Blood vessels again are striking you. Small, medium-sized, large, lot of blood vessels. So it's a foreplay of spindle cells and blood vessels. That is what you infer from these histopathologic slides. Before you come into a conclusive or at least near to histopathologic HND diagnosis, what should you do? Sum up the positive histopathologic findings. Peripheral acellular area, deeper cellular areas. Two zones are clearly seen here. So you can think that maybe the zoning phenomenon, which you see in some of the vascular tumors. Predominantly spindle cells, which are proliferating in streaming fascicles. You don't have atypia there. Foci of background inflammatory cells was seen in some of the slides. What struck you again was the numerous medium, large endothelium lined vascular spaces. So you might all have in your mind that what is the cell of origin? Is it hemangiopericytomatous? Because you are seeing lot of blood vessels here, though not exactly staghorn, but something resembling that, which you would like to see in pericytoma, which is now called solitary fibrous tumor, or is it something else? Fibrous. So our differential diagnosis, histopath HND differentials, should be centered around that. It can be a schwannoma, all said and done, because it is a spindle cell lesion. Fibromatosis. If it is intrabony, you should consider desmoplastic fibroma. Because it is soft tissue, we are considering fibromatosis. Myofibroma and inflammatory myofibroblastic tumor from myofibroblasts. I will come to that a little later because now there is an update regarding these lesions. Solitary fibrous tumor, what I earlier said, hemangiopericytoma. I literally, in fact, all three of us, when we had a look at this lesion, we actually had a strong notion of hemangiopericytoma first because of that vascularity. Leiomyoma. So these are all the lesions which we can think of. So we went into those markers. There is no point in going for cytokeratin right here because we should rule out these pathologies. So Vimentin we did was positive. It is a routine. S100 negative. So what does that mean about? Nerve origin. Smooth muscle actin positive. So what does that tell you? It could be either smooth muscle in origin or myofibroblastic in origin. Both are positive for smooth muscle actin. Desmin and caldesmon both were negative because we wanted to rule out leiomyoma, smooth muscles. So if these were positive, then we could think of smooth muscles. But since these are negative, we can completely rule out smooth muscles. So that is how when you have a marker which is positive representing two tissues, you should always try to rule out one of those tissues. So we went for smooth muscle first. So Desmin and Cal-Desmond were negative. So that ruled out the possibility of a leiomyoma. Beta-catenin, why we did was because it is positive in fibromatosis. It is also positive in osseous tumors, but since osseous tumors are not considered here, we don't speak about that now. Beta-catenin, if it is positive, we should consider fibromatosis or desmoplastic fibroma, but that was negative here. So that ruled out fibromatosis. CD34 and 31 and STAT6. These are vascular markers. STAT6 is a very recent fusion gene, which is very specific to solitary fibrous tumor. So if both these were negative, we ruled out solitary fibrous tumor. We actually had hemangiopericytoma first in our mind. That is ruled out now. ALK, that is also a gene fusion defect. That is anaplastic lymphoma kinase, which is very characteristically expressed in inflammatory myofibroblastic tumor. That was also ruled out. So what is left? Smooth muscle actin positivity, smooth muscle myofibrosis. Conventionally, it is considered myofibroblastic in origin. The solitary type is myofibroma. Here also it was solitary. Diffuse type is myofibromatosis. Very common in pediatric population. This was a 15-year-old girl whom we got this. Here, I want to give you an update, especially for the exam going pages. In the 2013 classification, hemangiopericytoma was shifted from pericytic tumors to fibrocytic tumors and was renamed as solitary fibrous tumor. In 2020, myofibroma has been included along with myopericytoma and pericytic tumors. So myofibroma now, according to WHO classification, is not under myofibroblastic tumors. It is gone under pericytic tumors. The rationale which the WHO gives for this shift, all tumors which show distinct hemangiopericytomatous vascular pattern, dilated, tortuous, staghorn-like vessels, have been brought under the broad category of pericytic tumors. And also a new subtype, cellular myofibroma and cellular pericytoma, has also been included, wherein you have less of vasculature, more of spindle-shaped cells. Then what about the IHC? There is a mention about the IHC panel also. Myo1b, that is myosin 1b, is thought to be a definitive IHC marker for pericyte. It is negative in vascular smooth muscle cells, but positive for pericytes. For IHC diagnosis of pericytic tumors, including myofibroma, what is recommended is the staining pattern of a panel of markers has to be evaluated to get a final diagnosis. Myo1b, SMA, and HCD. HCD is high molecular weight Cal-Desmond. Cal-Desmond is highly positive in smooth muscles. So a panel of these markers, the result has to be evaluated to get the final diagnosis of a pericytic tumor. Myofibromas are Myo1b negative, SMA positive, and Cal-Desmond negative. So this panel will, the result of this panel of markers will give you the final diagnosis of pericytic tumors. I don't have more idea on this because this is just a recent update. I have not read any articles further regarding this. So I thought I will just include this because this is helpful for the PG students. The picture quiz 2, take a minute, 30 seconds. Very explanative. Keep in your mind, PG students. My last case before I stop, 74-year-old male patient, 2 months swelling in the posterior mandible. Again, a very rapid growth. You can see the radiograph here, it's a CT. So what do you see here? Extensive, I'm not going to tell you the pattern here. You can have it in your mind because if I give you the pattern, the diagnosis is out. So think of what pattern you are seeing. And what will be the differentials based on this? Again, benefit of the doubt has to be given for an odontogenic lesion because it is mandible. An aggressive odontogenic lesion, osteosarcoma, definitely, because you are seeing that rapid growth and the pattern. The fibro-osseous lesion, chronic sclerosing osteomyelitis, not in this case, but why I included it is you have to include it if it is a long-standing lesion. Metastatic carcinoma prostate can occur in the mandible as a radiolucency in the mandible, especially in older male patients. So all these can be considered when you get such lesions. The slide, again, a highly cellular mass here with eosinophilic areas. You can see they are plump spindle-shaped cells. Some of them are angulated and they appear to be around some eosinophilic material closely associated with these cells. You can see the morphology of these cells. You can see the pleomorphism. They are highly aggressive appearing, stellate, angulated, pleomorphic, different shapes. They appear to be producing what is osteoid, what you can consider as osteoid. Higher power view, you can see the malignant nature of these cells. They are highly pleomorphic. They appear to be bordering the osteoid, enclosing the osteoid material inside. How do you know that this is osteoid? Bone-like structure. Pleomorphic atypia of these cells. So that tells you that this is a malignant neoplasm. But when you have areas like this, you have to be a little careful. When you don't see osteoid, when you are not able to appreciate osteoid, and when you get areas like chondroid areas, and that too malignant chondroid, malignant cartilage, which is pleomorphic, not even benign, you have to be a little careful in diagnosing. Since we have osteoid here, our diagnosis was straightforward. But what I want to tell you is you are likely to get areas where only pleomorphic malignant cells are there with such chondroid areas, without actual areas where you can appreciate osteoid. These are a diagnostic dilemma. So what are your positive features? You have to look at osteosarcoma chondroblastic variant versus chondrosarcoma. A very, very distinct diagnosis needs to be made because they are two distinct lesions. Parent tissue is different, treatment is different. So your diagnosis has to be different, has to be accurately made. So chondroblastic osteosarcoma, though you will have varying amount of hyaline cartilage, it will be intimately associated with osteoid or bone matrix. Somewhere, scan all the slides, scan all the sections. You finish off the entire tissue given to you. You will somewhere find the tumor cells directly producing osteoid. If that is seen, you have to diagnose it as a chondroblastic variant of osteosarcoma. When cartilage predominates with no osteoid production by tumor cells, you have to think of chondrosarcoma. I also want to give you 2 points to remember while diagnosing such osteosarcoma versus chondrosarcoma. Even though a lesion is composed chiefly of malignant cartilage, it should be diagnosed as osteosarcoma if significant malignant osteoblasts and osteoid or bone can be identified, because the course of the lesion will be different in both the lesions. Also, in an adolescent patient, if you are showing a tumor which is full of chondroid tissue, it should be diagnosed as chondroplastic osteosarcoma unless proven otherwise, because chondrosarcoma usually arises 2 decades later than osteosarcomas. So these 2 points you have to keep in mind while you approach such cases. So we diagnose this as chondroblastic variant of osteosarcoma. Picture quiz 1. I'm sure you all diagnose this as verruciform xanthoma. You can see the lipid-laden, the xanthoma cells here with the typical granular appearance. Very, very typical. So this is what you will see in a case of verruciform xanthoma. A white lesion with a granular surface, that is how clinically it appears. And in histopathology, you will find this. You would all have guessed correctly, lymphangioma. You can see the large dilated vessels where the periphery, you can see the flattened endothelial lining. The clear case of lymphangioma, again, the most common site of occurrence is tongue. So you have to consider lymphangioma also when you consider benign lesions, nodular lesions which can occur on the tongue. But this will have a typical clinical appearance like a frog's egg or tapioca pudding appearance. So my take-home message, especially to the PGs who are now giving exams, and after your exams, you will start practicing pathology, clinical pathology, of course. While reviewing the slides of potential connective tissue pathology, keep in mind 2 points. The lineage, see, the connective tissue cell basically arises from a mesenchymal cell precursor, which is spindle-shaped. From there, they go into, differentiate into different blast cells, which may either be spindle-shaped or round. The adipocytic cells, the lipoblasts are round, rhabdoblasts are round, but fibroblasts, the smooth muscle cells, the nerve cells, they are all spindle. That is the reason why you get 2 population of cells in spindle cell lesions. Either you get, predominantly you get a spindle cell lesion, or you may get round cell lesions. More predominant are spindle cell lesions. So in routine HND stains, many of the cases, you will be able to make a diagnosis only of spindle cell or round cell lesion. After that, you form a panel of markers for IHC to rule out the cases. So this is how you should approach a connective tissue pathology.